Hello and welcome. Today we're diving deep into a condition affecting the urinary system, specifically a disorder called vesicoureteral reflux, or VUR. We'll explore what it is, why it happens, how it's diagnosed, and what can be done about it. So, what causes vesicoureteral reflux? In essence, it stems from a problem at the junction, where the ureter, the tube carrying urine from the kidney, connects to the bladder. Ideally, this connection acts like a one-way valve, preventing urine from flowing backward. In VUR, this valve is either malformed from birth, known as primary VUR, or it fails due to another condition, like frequent urinary tract infections, resulting in secondary VUR. In primary VUR, the ureter is shorter than it should be and thus less competent as a valve. In secondary VUR, bladder problems or blockages can raise the pressure in the bladder, overwhelming the valve's capabilities. Now, let's talk pathophysiology. In a healthy urinary system, urine flows smoothly from the kidneys, down the ureters, and into the bladder. When the bladder contracts to empty, urine is expelled through the urethra. With VUR, however, during bladder contraction, urine flows backwards, or refluxes, up the ureters and potentially all the way back into the kidneys. This backflow is problematic for several reasons. First, it can carry bacteria from the bladder up into the kidneys, significantly increasing the risk of kidney infections, called pyelonephritis. Repeated or severe pyelonephritis can scar the kidneys, leading to long-term kidney damage and potentially even kidney failure. Vesicoureteral reflux is predominantly a pediatric condition. While it can occur in adults, it is far more common in children, particularly infants and young children. The exact prevalence is difficult to pinpoint, as many mild cases go undiagnosed. However, it's estimated that a significant percentage of children with urinary tract infections may have underlying VUR. There also appears to be a genetic component, with siblings of children with VUR having a higher risk of developing the condition themselves. The signs and symptoms of VUR can vary depending on its severity and whether or not kidney infections are present. Some children with mild VUR may have no noticeable symptoms at all. However, the most common symptom is recurrent urinary tract infections. These infections can present with symptoms like fever, pain or burning during urination, frequent urination, urgency, and bedwetting in children who are already toilet trained. In severe cases, where significant kidney damage has occurred, symptoms might include high blood pressure, protein in the urine, and even kidney failure later in life. Diagnosis of VUR typically begins with a suspicion based on a history of recurrent UTIs, especially in young children. The gold standard for diagnosing VUR is avoiding cystoarthrogram, or VCUG. This test involves inserting a catheter into the bladder and filling it with a contrast dye. X-rays are then taken while the child urinates, allowing doctors to visualize the flow of urine and identify any backflow up the ureters. Another test that can be used is a radionuclide cystogram. This test uses a radioactive tracer instead of contrast dye and exposes the child to less radiation. Renal ultrasound can also be used to look for kidney swelling that could be caused by reflux. VUR is often graded based on the severity of the reflux. The International Reflux Grading System classifies VUR from grade I to grade V. Grade I involves reflux into the ureter only, without any dilation. Grade II I involves rux into the ureter and renal pelvis, without dilation. Grade IV involves mild to moderate dilation of the ureter and renal pelvis. Grade IV involves moderate dilation of the ureter and renal pelvis. And grade V involves severe dilation and torosity of the ureter and renal pelvis. The grade of VUR helps determine the appropriate course of treatment. Treatment for VUR depends on the grade of the reflux, the age of the child, and the presence of kidney infections. Mild VUR grades I and II often resolve spontaneously over time as the child grows. In these cases, a strategy of observation with prophylactic antibiotics, meaning low-dose antibiotics to prevent UTIs, may be recommended. However, for higher grades of VUR, grades I through V, or in cases where UTIs are frequent despite antibiotic prophylaxis, surgical intervention may be considered. Surgical options include open surgery, where the ureter is reimplanted into the bladder to create a better valve mechanism, or endoscopic surgery, which is a less invasive procedure where a bulking agent is injected into the ureteral orifice to improve its function. More recently, robotic-assisted surgery has become another option. While VUR itself is not always preventable, particularly primary VUR, steps can be taken to minimize the risk of UTIs, which can worsen the condition. These steps include practicing good hygiene, such as wiping front to back after using the toilet, and ensuring adequate fluid intake to flush out bacteria. Prompt and effective treatment of UTIs is also crucial to prevent them from ascending to the kidneys and causing further damage. The prognosis for VUR is generally good, especially for lower grades of reflux. Many children outgrow VUR without any long-term complications. However, regular monitoring is essential to detect and manage any potential problems, such as kidney scarring or hypertension. Recent research is focusing on identifying genetic markers for VUR to better predict which children are at higher risk and may benefit from early intervention. Additionally, research is exploring new minimally invasive surgical techniques to improve outcomes and reduce complications.